My task is to introduce our annual report. This is primarily about the safety of mental health care, with an emphasis on suicide prevention. It's a long report, so I'll be talking selectively from it. There are quite a lot of graphs to go through. Sometimes we go through them quite quickly, so bear with me on that. And I want to stress right from the start that every one of those graphs, every one of those line diagrams, all that you're about to see, all the numbers on the slides are real people. They are real lives lost, real families devastated. We never forget that in our work. We work a lot with families, and we never forget the reality that lies behind our statistics. Let me start screen sharing now. So that should now be about right. Like much else, our work has been impeded, but also shaped by the COVID crisis. We are going to talk this morning about some of the work we've done on mental health services, but an important part of our work in the last year has been to support the NHS and suicide prevention leads in local areas with the suicide prevention task during this unprecedented period. And one of the questions that has been most pressing is what the impact of COVID has been on national suicide rates. We've set out to answer that question using data from what's referred to as real-time surveillance, RTS. You can see the paper that we recently published on this on the slide. We need RTS because coroners' verdicts, coroners' conclusions, and the ONS, Office for National Statistics, figures that are based on them don't come through quickly enough to answer an immediate question. And so we use RTS, which is in operation in a number of parts of the country. Because we work with STPs, the current NHS regional division, we work with them anyway. We aggregated the data that they had, some of them at least, those that have been collecting data in a substantial way for a period of time, and to give us an impression of the national suicide rate. There were 10 STPs, total population 13 million people, and that's about a quarter of the country. They're marked on the map there, and you can see there's a preponderance in the north and in the southwest where suicide rates tend to be highest. And we studied the period before and after the pandemic began, the months before, January to March 2020, and the months after, from April up until October. The second wave began in November, so it's essentially from the first to the start of the second wave. And here's the main result. Let's just bring up the laser pointer. So these are the suicide rates for that quarter of the country, that 13 million people. Here are the suicide rates pre-pandemic in those areas, and here post-pandemic, or once it had started, I should say. And essentially there is no change. And in fact, if anything, if you look at the figures here, the period after the pandemic started, the national rate in these areas at least was a little bit down. I don't think we should make too much of that. Essentially no change from pre to post pandemic. There was no significant rise in any individual month, and there was no rise in the 2 months that people were most worried about, April and May, when the first lockdown period was at its peak. We had some data for 2019, so we were able to compare with the previous year, although there was an issue of data quality about earlier. These systems are early, remember, but we didn't find any difference when comparing to 2019. And so we concluded that the large national rise that many people feared, remember people were talking about a huge escalation in suicide, that large national rise has not occurred. And that further than that, in these areas, and I need to stress that, in these areas at least, we weren't seeing a rise in suicide that many were concerned about. And in fact, over the last year, that has been a consistent message from most countries that have been reporting. However, there are quite a lot of caveats about this finding. First of all, these are early figures. They cover the period up to October last year. They don't tell us what's happening right now, though we are still working on it. It may be that beneath the headline data, there is local variation. Some parts of the country affected more than others. Some groups affected more than others. After all, the impact of COVID itself has not been uniform across communities. And then RTS itself, it is still a new method of estimating the national suicide rate and will need further development. I suppose most of all, for those of us who are in the field of suicide prevention research, there remains the concern that over time, as economic adversity becomes the dominant consequence, that still may put up the suicide rate, and we have to be alert to the continuing importance of suicide prevention. Why, when there was so much distress, there are credible reports of greater distress in many groups, and this is not to question those reports. They are absolutely believable, and we have to explain how both things can be true. I suppose, first of all, suicide rates don't always follow levels of mental disorder. Suicide is complex. One of the important messages of today's report: suicide prevention is complex, suicide is complex. It isn't a straight step from levels of mental disorder to suicide rates. Otherwise, women would have much higher suicide rates than men, higher rates of anxiety and depression, but men have higher rates of suicide. So it's a complex relationship. It may be that there have been protections in somewhere, that as well as greater stresses for many people during the COVID period, there have also been more protections, scrutiny and vigilance from family and friends, perhaps a wider response from society, social coherence, a sense of getting through it together. And it may be that access to certain suicide methods has been reduced. We've tried to extend the method of real-time surveillance to patient suicide. This is not using the same source. This is now going to clinical teams nationally and asking them to report to us deaths of patients who they are, when they're aware of those. So we collected data from the start of the first lockdown for the first 6 months to see whether we could draw lessons about mental health care from that early clinical experience. The first thing to report is that a voluntary reporting system is always less reliable. I'll say in a minute how we do the inquiry in general, but relying on voluntary notifications led to, during that 6 months, 133 deaths being notified to us. Now that's a lot of individual tragedies, but it is probably only about a quarter of the expected number of patient deaths. So we can't draw many conclusions from the figures themselves, but the themes they are raising are still important. First of all, although we've been concerned about acute care and access to crisis care during the pandemic, most of the patient suicides that occurred happened in the community under CMHTs, under long-term care. Secondly, many of the people, the majority whose tragedies we heard about, had also experienced adversity in relation to the pandemic, whether loss of job or other economic pressures, anxiety about the illness, and isolation. About a third had had disruptions to their mental health care, either loss of facilities that they relied on or disruption to their relationship with people who supported them. So the prevention messages were clear. Even though the rate of suicide doesn't appear to have risen, the pandemic has still affected people's experience and individual risk. Now onto the report itself. This is our 2021 report, but in fact, it is a delayed report from last year because of the pandemic. So it is essentially a report that we would have brought out during last autumn. We mainly report on patient suicide in this report, and this is not by real-time surveillance. This is using the official ONS statistics, so coroner-confirmed suicide deaths. And our data process is based on 3 stages. Stage 1, we collect all, from national sources, we collect all suicides that have happened across the UK from ONS and from other official statistical sources. Second, stage 2, we establish which of those people have had contact with mental health services, meaning that they were in contact with services in the previous 12 months. So a 12-month criterion for being a patient. So here us referring to patients, we mean 12 months contact. In stage 3, we send a detailed questionnaire, a standardized questionnaire, to the clinicians, the clinical teams, to provide us with information about what was happening in people's lives. And the response of the service is tremendous. 95% of our forms are returned. And if you're one of the people who has sent us information, we must genuinely thank you. We cannot do our work without the cooperation of clinical services. So in 2020, which is when this report might have come out, the most recent year where we would have complete data would be 2018. And that's because it takes time for deaths to be confirmed at inquest and time to collect the data. 2018 in our data, because we go by date of when a death occurs, approximates to 2019 for ONS, who record dates by registration of death. So these are the most recent figures that you could see on patient safety. We deal with very large numbers. It's a very sobering thought. Some of the figures are truly distressing. In the 10-year period of the report itself, there were over 66,000 suicides in the general population, of whom 18,000 were mental health patients by that definition. So that's 27% of people who were recently under mental health care. And you can see the breakdown of the figures by country. This is a UK-wide report, but because of the numbers you see on that slide, many of the figures are driven by England data because of the larger population. We were able to show the numbers year on year and look for any sign of change. And this is the total number of patients who die by suicide under mental health care leading up to the most recent year. So you can see that in the final year there, 1,601 patients, 1,600 patient deaths. Again, just worth pausing on how large these figures are. 1,600 people died while under recent mental health care. And although the line looks fairly flat in recent years, it is fairly flat in recent years, it is slightly higher in 2018. An extra 60 deaths, just under 60 deaths more in 2018 than in the previous year and in recent years. Most of that rise, almost all of it, comes from England. So what we're reporting is a case series. We're reporting about the people who died and the circumstances. It's not a case control study, it's not a risk factor study, but we are able to comment on the circumstances, the antecedents, the things that seem to be happening for people when they take their own lives. And that gives us what we often refer to as a risk profile, the balance of risk factors. What would be the target, is the question, of prevention? What should we do on the basis of what we know about people's lives in that critical period? Now, you might say, well, those are numbers, but haven't we seen rather more patients coming into mental health care? And that's certainly true in recent years, a much larger number of people seeking mental health care. And here is, therefore, a calculation of rates. So this is now those numbers taking into account how many people are under mental health care. And this is England only. The green line in the middle is the rate, male and female rates either side. And you can see that, in fact, the rates, once you take into account the number of people under care, the rates have been falling in recent years, although in the last couple of years, there's probably, that fall seems to have leveled off. And the fall has been larger among but among male mental health patients. So what could you say? Well, by this measure, mental health services appear to have become safer. That's not what we always hear about services, but that's what the data suggests. Every year we talk about suicide in certain clinical settings. Inpatient suicide, a very important one for us. When we started collecting data on inpatient suicide 20 years ago or so, there were over 200 deaths a year among inpatients. Now the figure is down to around 70. So that's a very large fall. And even in the last 10 years of our annual report, the numbers have fallen by about 41%. A couple of years ago at this event, we warned that the progress on inpatient suicide had stalled, and we needed a further push to improve inpatient safety. You can see why we thought that in the first part of the graph here, fairly level numbers. But in recent years, those figures have come down again. And so we're now seeing a drop, and that drop is mainly driven by England. What do we know about these deaths? Well, we call them inpatient suicides, but only about a third happen on the ward itself. The majority are people who are leaving the ward with staff agreement, usually towards the end of an admission, planning to return to lives, perhaps finding life outside hospital being stressful, difficult to deal with, problems perhaps awaiting that brought them in the first place. And so the message for prevention is, again, that suicide is not one thing, not even inpatient suicide is one thing. Suicide prevention, not one thing. We need safer wards, we need better transitions to the community, and we need to protect people who find the wards difficult and who leave the ward without staff agreement. 16% of suicides are in that category. In fact, the highest period of risk is the immediate post-discharge period after leaving hospital. And in that time, we've been studying that time for some years now. The figures, the most recent figures for 2018 are lower. In the last 3 or 4 years, those figures, just like inpatient care, a little bit lower. 179 people die within 3 months of leaving hospital, but it does remain the highest risk period. This graph is a little bit different from the others. It's not showing year on year at the bottom axis here. It's showing week by week deaths after leaving hospital. So here's the point of leaving hospital, and here are the first 2 weeks. And you can see that the risk is not uniform during that 3 months. It's at its peak during the first 2 weeks. And in fact, it's more than that. The highest risk is actually on the second full day after leaving hospital. And for that reason, one of the main suicide prevention approaches of mental health services needs to be to manage that transition to the community, early follow-up for people who are leaving hospital. And that now has become much more of a routine and a requirement, in fact, in mental health care. Every year also, we report about patient homicide. Now, this is an incredibly sensitive issue because of the concern that even talking about it may add to stigma. But it's an important part of safety. It's a tragedy in so many ways, including for the person who is the perpetrator. And so we've been monitoring patient homicide numbers for some years. We no longer carry out a detailed exploration of the circumstances, but we do still record the numbers. And that work is led by Professor Jenny Shaw, who will be on the panel later. You can see that in the most recent years, the figures are relatively flat, perhaps falling a little bit, just between 40 and 50 deaths a year. That's still a lot of incidents, but compare it to suicides. 11% of general population homicides are by patients. That compares to 27%, if you remember, about suicide. Around 40 to 50 patients a year committing a homicide, compared to about 1,600 deaths by suicide. Now, in every year's report, we have a number of special themes, and this year the themes are partly driven by what we were concerned about in relation to COVID. So let's be clear, this is not a report about what was happening under COVID, but it does reflect some of the groups who became of most concern during the COVID period: young people, patients from ethnic minorities, and those who live alone. So just a couple of slides about each of those groups. First of all, a graph showing the numbers, and the dominant message about young people, as people under the age of 25, is that the figures continue to rise. There are over 600 deaths a year now by suicide in the general population, in people under the age of 25, of whom about just over 21%, about a fifth, a little bit less than that 27%, are mental health patients by that 12-month definition. So that's around 134 deaths a year. 134 under 25s die by suicide, those who are patients. And you can see that the graph here is dividing the under 25s into those who are 20 and above, that's the top line, and those who are under 20. And the graph tells its own story. The rise has been steeper in the younger group. And in fact, if you break that line down a bit further, it's even steeper in those who are under the age of 18. It's also steeper in women. So these rises are being partly driven by the youngest patients and by female patients. What do we know about those people? Well, it's a reminder again that this is a case series. It's not about risk factors. It's telling us where our prevention efforts should go, and it's telling us about the complexity of suicide. It is not one thing, and nor is prevention. 25 deaths a year are in young people who are current or recent inpatients, so inpatients or recently discharged. There are some differences with older patients. More people with a diagnosis of personality disorder or eating disorder. Personality disorder is not our favorite diagnosis. We are not keen on it. We've written a report about it, but it's in common use as a diagnosis. So we refer to it here because that's what the clinical term is in the data that we receive. About a third of these young people have got quite complex clinical histories, additional diagnoses, a history of self-harm, sometimes substance misuse. And so our services need to have that ability to cope with the complexity that patients present with. 15% of those young people had used the internet in a way that was relevant to suicide. Not just social media, it's also about searching for suicide methods. Our second group, ethnic minorities. So here is the equivalent graph. This is the numbers over the 10 years of the report. And although there's some volatility in the figures, there is no overall rise. About just over 100 deaths a year among people from ethnic minorities who are patients, about 7% of all patient suicides, roughly in line with population figures. But when we come to look at the detail of who the patients are, then it becomes more complex. Even defining ethnicity is complex. Ethnicity is not recorded at inquest. A lot of us think it should be, but it is not. So we record ethnicity from the clinicians who give us data. And we have defined ethnicity in the report according to what they've told us. And I suppose the dominant message here is that there is no single risk profile across ethnic minorities. There is variation in the balance of risk factors from one group to another, and the prevention task too is therefore varied. Maybe we should stop talking about ethnic minorities as if they are one group. They are a diverse group of people with different needs for prevention. Here are some examples. South Asian patients, a different risk profile. Some standard risk factors like living alone, less common, more likely to be with families, but more depression and less of a common risk factor, substance misuse. So a different profile than what you might find elsewhere. For Black Caribbean and Black African patients, the risk seems to lie mainly in severe mental illness, and for some, in the comorbidity of alcohol or drug misuse. For Chinese patients, the majority are female. That's a very unusual finding in suicide prevention, where males dominate almost every study you look at. But the majority of Chinese patients who die are female. That's the suicide prevention task. Incidentally, it's also true of mainland China. And a short history of illness, so the window of prevention is short. And then there are people who have multiple or mixed ethnicity, and their characteristics draw on the other groups, more often living alone, as some of the groups are, more often showing a history of self-harm or substance misuse, or from our point of view, opportunities to intervene. So different characteristics. Thirdly, people who live alone. So here are the figures. And the top line is the patient population. So remember, 1,600 deaths a year altogether. Almost half of those patients who die are living alone. A very sobering fact. Half of the patients who reach the point of suicide under our care are people who live alone, so lacking the support that in one sense might protect them. Who are they? Well, the first characteristic is that they seem to have a loss of connection. They live alone, but there's a wider loss of connection with broader society. No job. Their marital status is often single or perhaps widowed. They are in financial difficulties. Money is a connection to society. They are losing it. Relationship breakup. They're losing the relationships that keep them connected. So they're not just living alone. They have a disconnection from support in a much broader sense. Meanwhile, their risks are higher. they not only live alone, but common risk factors like substance misuse and self-harm are more common than in other patients who die. And they have high rates of physical comorbidity, presumably contributing to the fact that they live alone and to their isolation. A further reminder, suicide risk is complex, suicide prevention is multifaceted. And then our fourth and final theme, and I mentioned this in this talk with some hesitation. We had to decide whether we would present the data here today. This is a very difficult and sensitive topic. It's about suicide method. And so I would just ask if this might be a triggering topic for you. You might want to drop out of the presentation for the next minute or so. These are the suicide methods that patients die by. The reason we're presenting this, and despite the sensitivities, is I think it is very important for the services to be aware of what's happening to suicide method. In suicide method among patients, as in the general population, we are seeing the relentless rise of hanging as a suicide method, more and more common, while self-poisoning and other methods like jumping from a height become less common. It's been happening over some years, and it is particularly true of female patients and particularly true of under 25s. So those groups that I mentioned earlier are showing further rise. And in fact, it may be one of the reasons for the rise. You know, we talk about rates going up in women and young people, and we think of social and clinical explanations why that might be true. But one of the reasons might be that in self-harming episodes, they use a more lethal method than they used to. Very important thing for us to try to intervene on, but very difficult outside institutional settings. What information can we use for prevention? We know that some of the people who die by hanging also have protective factors. They're often employed and married, not the conventional profile. And maybe that's reassuring to the clinical teams who see them, falsely reassuring. There's a sense of recency, recent onset, depression, recent life events, often financial or relationship or workplace. So a sense that this is a crisis that's relatively recently started. Maybe that's reassuring to clinical teams. And a sense too of escalation. Quite a large minority have recently been seen for another episode of self-harm. So a sense that their escalation, the lethality, if you like, of what they do is being stepped up. And so that point at which prevention might occur, the preceding self-harm. So finally, what about the clinical messages on the basis of this? I'm not going to go through all the clinical messages that are in the report, but let me just highlight a couple before I finish. We have people under the age of 25. The issue here, as with so many of the others, it's about the personalization of suicide prevention, about the complexity of the task, the clinical complexity, about the variations in risk profile, and about the diversity of the job that we face. Those words are key to this report: personalization, complexity, variation, and diversity. So for young people, the clinical complexity has to be something our services can respond to. Sometimes our services are single specialty and they are not good at responding to the comorbidities, and sometimes they even exclude people because of comorbidities. For patients from ethnic minority groups, well, I've talked about the variation across ethnicity, and our services need to recognize that variation in responding to the challenge. And for people who live alone, again, there is this clustering of risk factors, the combination of risk factors across individuals, and making more complex the suicide prevention task for this very large group who live alone. And then on COVID, on COVID too, we can see a disruption to care for some people, putting some people at risk. And that disruption to people's lives, but also to the clinical care that they rely on, a key part of how we take prevention forward as the pandemic evolves. All of that in the end is to back up our key message in the last couple of years about suicide prevention. We refer to it as the 10 ways to improve safety, the main ways and interventions that can make a difference. We've done a whole series of studies that have highlighted these particular 10 ways to improve safety in clinical care. This is how we depict them. And just to point out one or two that you've heard from me today, Here is safer wards. Here is early follow-up on discharge. Here is addressing alcohol and drug misuse. Here, talking about low staff turnover as a protective factor, the continuity of care that we referred to, loss of continuity being the risk. Here is the personalized risk management. Suicide is complex and involving families, the families and what they know about risk and what they can add to prevention. Involving families, leaning to a learning culture. I hope it's been useful today to learn from our data. Thanks very much.